going to talk about acute surgical abdominal issues that come up. There's a lot of patients will come with ER visits or even to their primary care or urgent care with abdominal pain complaints. And the differential for abdominal pain is obviously very vast. And there's many, many things that can cause it. Anywhere from medical things to surgical things to nothing to really bad problems. And so I thought we would go over some of the more common acute complaints that sort of need to be addressed and you need to keep in the back of your mind. So, you know, what probably the most common, or now maybe second most common, abdominal acute issues is appendicitis. Everybody's heard of appendicitis. Appendicitis affects roughly how many people do you think, or what percentage of people? Yeah, it's maybe even a little more. It's probably about 1 in 8 people will get appendicitis in their lifetime, which is quite a lot. So there's more than 8 of us in this room. Somebody's got to have appendicitis at some point. Ramiro, I recommend you.
Okay, no, please.
So it affects all age groups. There is no age predominance. It affects children to young adults to middle age to elderly. It affects everybody. What's the most common or typical clinical presentation that they usually come with? What's the history?
They have pain, nausea, vomiting.
So let's talk about the pain. Where does it usually hurt?
I think it starts epigastric periumbilical and then migrates to the right lower quadrant.
Typically does, yeah. Typical pain they describe as this migratory classical pain that goes from the belly button to the right lower quadrant. Anybody know why it does that? Because nothing else has a migratory pain except appendicitis.
Dermatomes?
Sort of.
The spread of the inflammation.
Yeah, this one.
Okay.
Visceral.
So what's the periumbilical pain they're having? What is that from? That's the visceral pain. So the appendix is inflamed, it's swollen, it stretches, and stretch of the bowel, just like a bowel obstruction or anything that causes abdominal visceral pain, is felt as this generalized periumbilical pain. As the appendix becomes more inflamed and it sits up against the peritoneum of the right lower quadrant, the peritoneum gets inflamed secondarily. And then inflamed peritoneum is very painful. So then they start feeling the pain over there. The initial visceral pain is still there, it's not gone. But because the peritoneal pain is so much more severe, you sort of forget or are distracted from the other pain, and so they think the pain moved. Interestingly, if the appendix doesn't sit up against the peritoneum and doesn't cause a peritoneal inflammation, you won't have right lower quadrant pain or that migration. And so that could be if they have a retrocecal appendix, where the appendix is behind the cecum, or if their appendix is covered in other things, like it's in between loops of small bowel or under a layer of omentum, where if the inflammation is not quite reaching the peritoneum, that area won't be quite that tender. Okay, so pain that's migratory, that's typical. Typically, how long a period of pain do they complain of having?
6 hours.
So it's variable, depends on who the patient is. Usually women will come in earlier. Children will usually come in a little bit later, just because by the time the parents figure out this is like real pain and it's not just I ate too much or something, and they don't complain as readily. Men tend to just ignore things and sometimes come in later, but people are also different, and so it just depends on what's been going on. Typically they'll talk about these 12 hours of pain, versus 24 hours. Sometimes people will come in, they've had days of pain. But usually it's more acute. If it's been weeks of pain, then it's very unlikely to be appendicitis. Okay. So we talked about the onset and duration. Is the pain they're having usually pretty constant or intermittent?
Constant.
It's pretty constant, yeah. There's nothing that's going to make it fluctuate except for there's a few things that make it worse. What do you think those things would be?
Jumping. Walking.
Okay.
Like the heel tap. Can you do the heel tap?
Anything that moves their perineum, right?
Yeah.
Anything that moves their guts and causes things to touch the abdominal wall or move the abdominal wall is going to increase pain. Okay, so the drive to the hospital, walking to the gurney in the room, jumping, tapping their heel. Sometimes if you don't want to give it away, when you walk up to the gurney and you just walk up and bump into it by accident, right? You'll know if they've got really bad pain. As you bump into the gurney, they'll scream out a little bit. So yeah, movement will basically cause pain. What are some associated findings that they'll complain of? You mentioned some nausea and vomiting earlier. Is it usually there? It's hit or miss. It often is, but not always. It's not necessary. Typically, the nausea or vomiting follows the pain, whereas with like gastroenteritis or intestinal infections, it precedes the pain. So usually, someone gets gastroenteritis, they vomit, then they get a lot of pain, right? With appendicitis, the pain gets so bad that they start vomiting. Okay. So that timeline also helps with making some decisions. Do they typically have diarrhea?
I don't think so.
What if they do have diarrhea? Would that make you think less likely appendicitis? So diarrhea is not typical, but it does happen with appendicitis sometimes, especially if there's an abscess or sigmoid colon's inflamed and stuff. It can happen. It doesn't exclude appendicitis, although diarrhea that preceded all the pain would make you think more of an infectious etiology. Okay. So we talked about associated things. What are some of the differentials that you want to exclude or rule out for right lower quadrant abdominal pain? So everybody give me one.
Obstruction.
Okay, bowel obstruction. Here's what to make it easier for you, I'll tell you. When I think of abdominal pain, the easiest way to look at it is divide the belly into 4 quadrants. Okay? And think of the organs that are in the quadrant that the patient's having pain at. And that's, the top of your differential is going to be anything involving those organs in that area. So left upper quadrant pain, I usually don't think of appendicitis because the appendix is in the right lower quadrant. I have seen appendix in the right upper quadrant, and in people who have malrotation, the appendix could be in the left upper quadrant, but it's not the typical, right? So in the right lower quadrant, all right, bowel obstruction. Go on.
Crohn's.
Okay, inflammatory bowel disease. You guys are starting at the lower end of the differential. I mean, the most common things that cause belly pain.
Oh, I was going to say diverticulitis.
Okay, diverticulitis. Sometimes the sigmoid colon can come over to the right a little more, as it curves around. But typically, diverticulitis is a left lower quadrant pain.
Plausible perforation.
Okay, a perforation would usually give you more of a diffuse peritonitis. But if it's a focal perforation that's sort of contained, it can. Less likely, but sort of similar to diverticulitis.
Colon cancer.
Okay, colon cancer or
And age of the patient.
fine, fair enough.
I don't know if this is really out there, but
Okay, that would be typically more of an epigastric radiating to your back kind of thing. All right, give me some organs that are in the right lower quadrant.
Oh, I have one. What about a kidney stone?
Kidney stone, perfect. Okay, very common. Kidney stones cause right lower quadrant pain if it's the right kidney stone. Okay, usually flank pain radiating to the front. Yeah, perfect, good. Give me another one.
If it's a female,
Okay,
like ectopic.
half the patients are.
Yeah.
Anything related to the ovary and uterus. Anything. Ectopic pregnancy, ovarian torsion, tubo-ovarian abscess, PID. Okay? Any of those. All cause adnexal or lower quadrant pain. Okay? Give me another one. Different organ in the belly. Part of it's in the right lower quadrant.
Well, name an organ?
Yeah, give me an organ.
Terminal ileum?
Okay, give me a non-GI organ.
Non-GI organ?
Think about along the lines of what she said.
Is it
Which-
kidney? Kidney
She
stone?
said kidney stones.
Ureters?
Okay, where does the ureters go to?
Bladder.
Bladder. Okay, what can cause problems of the bladder that cause pain that are very, 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 very common? All right, help him out.
What causes problems with the bladder? So
Some kind of abdominal pain
UTI?
that can. UTIs, perfect. UTIs. All right, great. And also pregnancies along the lines of uterine, ovarian stuff. Okay, so most common things, right lower quadrant pain, you're going to think of UTI, you're going to think of, in a woman, any gynecological issue, okay? You're going to think of kidney stones. Then you're going to go to the more GI-related issues like cancers, diverticulitis, inflammatory bowel disease, and those things. And then there's always the gastroenteritis and stuff. Now, I'm going to give you a couple more things. What about, what's the most common finding, or give me the top 3 things, most common things that you go to surgery for appendicitis and the appendix looks normal? Okay, presumably you've already ruled out UTI and ovarian stuff, but let's say you go to the operating room and the appendix looks normal. What are the top 3 things you're gonna think about in the differential? Ever heard of Meckel's? Meckel's diverticulum, right? You heard of the rule of 2s? 2% of the population, it's usually 2 centimeters. It's got 2 kinds of tissue, right? Gastric tissue and intestinal tissue. It's 2% are malignant, and it's 2 feet away from the ileocecal valve. Okay. Meckel's can cause pain because it can get inflamed, but also you can get an ulcer opposite the side the Meckel is, because the Meckel has gastric tissue and it can secrete acid, and so it can cause inflammation of the intestinal mucosa on the opposite wall. Okay. Oh, thank you. So, Meckel's diverticulum. Most commonly, you think of mesenteric lymphadenitis, which is swelling of the lymph nodes in the mesentery of the bowel, which causes right lower quadrant pain. Classically, it's the #1 thing that's confused with appendicitis. There's no way to distinguish it other than to look at the appendix. Now we can look at the appendix with CAT scan, but that's really the basic thing. Patients with mesenteric lymphadenitis usually have a history of an upper respiratory infection or recently being ill or some kind of viral prodrome that's caused their lymphatic tissue to swell. And then, you know, the host of other things that we talked about already are the other things. So let's say a young, healthy male comes to the emergency room, 12 hours of pain, right lower quadrant, migrated from the umbilicus, It's getting worse and worse. They call you to come evaluate him. Now that you've come there, he's feeling like the pain got a lot better.
Perforated.
Very well may have perforated. So patients who perforate typically describe this pain that goes up, and then they have this brief period where it gets better. It bursts, the pressure is relieved, pain goes away, and then the inflammation builds up on the peritoneum, and then the pain starts to go up even worse than before. Okay. We talk about this all the time. It doesn't happen all that much because patients are like, just in pain all the time. When the ER calls you, do you say they're going to ask you, should we give him pain medication, or do you want to wait till you see him first?
Wait till you see him.
So you guys like to torture people.
I was just gonna say, you don't want to
Like
mask anything, right?
So can you mask peritonitis with narcotics?
Oh yeah.
Probably not, right? So I always say, treat him, make him comfortable. When I get there, he'll at least be comfortable enough to have a reasonable conversation, right? And I can get his history. He's not going to be in so much pain that he can't talk to me. But if you push on him, he'll still be tender. You have to understand the guy's not going to be screaming because he got pain medicine and he's a little more comfortable. But you can't make the pain go away. You can't mask it. Which is all the more reason when patients ask you to make their pain go away, they have to understand that that's not reasonable, right? You can't make it go away until you make them stop breathing. And that's usually not the approach we take to pain.
Is there any concern of, like, if you end up having to do surgery with the anesthesia and the pain medicine that you just gave them?
No, because they just give them more.
Okay.
You know, I mean, you want them to be comfortable. You also have to think pain treatment is one of their patient rights, and it's another vital sign now, within reason. Okay, you don't have to make people pain-free. You have to address their pain.
Okay.
Okay, and also if you leave somebody in a lot of pain, it's kind of cruel, and also their blood pressure is going to go up, their heart rate's going to go up, they're going to start sweating, everything's just going to start falling apart. But it's not necessary. If it's necessary, then yeah, you don't need to do it. You'd make them wait, but in this case, it's not. You're not going to mask it. There's tons of surgeons have looked at this stuff. You can't confuse the picture with narcotics. We used to say, don't give them anything until we see them, but it's pretty straightforward now. So you're going to go down there, and what's the first thing you're going to do when you get to the patient? After you introduce yourself, what's the first thing you do?
Get a history if it hasn't already been.
Perfect. Get a history. You want to get a full history. Even if they've already done it, you want to make sure they're telling you the correct information and the information is accurate. And once you're done with your history, what are you going to do? Physical. Good. I'm glad you didn't say order it labs or imaging first, right? First thing you want to do is talk to the patient. So 85 to 90% of your diagnoses can be made just off the history alone. With a history and physical, you can pretty much make every diagnosis, or at least come to a differential of 2 or 3 things that are most likely that you're going to confirm with labs and imaging. Okay. So you do that, and basically typical history, like I said, healthy guy, 12 hours of pain, and you examine him. He's got pain at McBurney's point, which is where? Where's McBurney's point?
It is, I don't forget the exact. How many? Okay, yeah.
ASIS and umbilicus, 2/3 of the way. Which way? Is it closer to the belly button or is it closer to the ASIS?
ASIS.
That's right. Okay, that's the most common location for the appendix. What if you're dealing with a pregnant lady?
Well, then it's going to be a lot closer to the ASIS, right?
So the appendix moves with pregnancy. As the uterus gets bigger, it pushes everything up. And so your appendix, depending on what week you're at, will move up. to generally roughly near the top of the fundus. So, you know, you just think of that where the fundus line is at 20 weeks, it's at the belly button. So their appendix is sort of near the belly button laterally. Full term, it's going to be up by their gallbladder. Okay. So that's something to think about. And then, so tender right there at McBurney's and not really tender anywhere else. What else do you want to check on your physical exam?
Do they have a fever?
Okay,
Just
they
like
can.
fever, yeah.
They don't always have a fever. Typically, fevers are more common if they've perforated or if they've got an
Okay.
abscess or something. But acute early appendicitis doesn't usually have a fever. Sometimes they don't even have a white count. They can have a totally normal white count for early appendicitis.
Mhm.
And when they do have a white count, it's usually not really bad. You know, it's just a couple points above normal, but not 20. You know, when it's really out of control, you're thinking of an abscess or something else too. Okay, so you mentioned the heel tap earlier. You could do that. What are some other exams you can do on the abdomen? What's that?
Rousings.
What is Rovsing's?
Is that the, let's see here. Is that when you press the opposite side? So it has the peritoneal irritation, right? So you press.
So you push on the
you
left
release.
side,
Yeah.
and when you're pushing on the left, they feel it on the right. The push and release is rebound.
I was gonna say,
Rebound.
Okay, very cruel way of examining someone, but it's a very effective way to know if they've got peritonitis. Okay, but Rovsing's is you push on the left and they feel pain on the right.
Mhm.
Why do you think that is?
The peritoneal irritation, or
You're not pushing on the peritoneum on the right.
is it all connected?
So yeah, what you're doing is you're pushing their guts over. So you're pushing the bowel over, which pushes the appendix up into the abdominal wall on the other side,
Okay.
instead of pushing the abdominal wall into the appendix on the other side. You know, you're irritating that peritoneum on the other side from the inside as opposed to from the outside. So Rovsing's, that's a good test for appendicitis. What else?
Right.
Obturator.
What's the obturator?
Is that, is the one where you bend your leg
Yeah, so you
Right.
flex the hip and knee,
and,
and you internally rotate, and they'll feel pain at that area. And then what's psoas? Psoas is the other one. How do you do it?
they lift their leg up against pressure, like of your hand, so that their legs out straight on that same side, on the right side.
That's one way to do it, yeah.
Right,
And
so,
and what does that indicate?
irritation of the muscle, right? Because the muscle connects.
Of the psoas muscle.
Yes.
So typically they have a psoas sign, most commonly if they have a retrocecal appendix.
Oh,
Okay, so if they don't have a good tenderness at McBurney's, but they've got a really obvious psoas sign, you're like, what's going on here? Okay, one of those things. Now, what you got to remember is anything that causes inflammation near the right lower quadrant will cause the same physical exam findings. So a tuberovarian abscess will cause those findings. Any abscess, like a diverticular abscess or anything in that area will cause those same findings. So it's classic of appendicitis, but anything that's causing inflammation of the right lower quadrant peritoneum will have the same pretty much physical exam findings, right? So history is important, and then the rest of your exam in a woman, making sure that they don't have pelvic findings or doing a pelvic exam, checking a pregnancy test, checking their urine, asking a history about their urine, dysuria, and those kinds of things. Those are all sort of things that will add up. Okay. And then you can do blood work. Typically, the blood work you need is a CBC. Sometimes people will do LFTs. LFTs, in my experience, your total bilirubin may be a little elevated, especially if you've got a perforated appendix. Okay, so if the appendix is perforated, the bilirubin tends to go up slightly. but that's just sort of one of those things you sort of learn along the way, but it's not in the books. And then they may have a white count, and you check their urine, make sure they don't have a UTI or something else, right? Any female that's of childbearing age, in other words, has had menses or is close enough in age to have menses, or someone who still has their uterus and has not hit menopause, you get a pregnancy test. Okay. And that's sort of the evaluation. Now let's say you find out they have appendicitis. So here's the part that gets tricky. You're going to see somebody and you're going to have there are going to be patients where you have a very high certainty that they have appendicitis. There's going to be patients you have a very high certainty they don't have appendicitis. And then there's going to be patients that are sort of equivocal and in the middle and you're not really sure. Okay, so let's say you've got someone that you're fairly certain does not have appendicitis. What do you do?
Discharge him.
So no, that may be reasonable. If you don't think they have appendicitis, then the question is, what is it that they have? Most other things are not going to be emergencies, right? Kidney stone or whatnot. Most of them are symptomatic treatment. You still check for everything else. You check for their UTI and all that. And if you think they've got a viral gastroenteritis or whatnot, and they're a reasonable patient that can follow up if their pain continues or gets worse, you can do that. What you can do is give them some food to eat in the ER, make sure they can hold it down, they're not going to go home and be dehydrated and whatnot, and then decide if they can go home or if they need to be admitted for hydration and other things. People with gastroenteritis still sometimes have to be admitted to the hospital too. But you don't have to follow up with appendicitis if you're fairly certain that they don't have it. Okay, so let's say somebody comes in, they're not tender at all, they had 2 hours of pain after eating something and it went away 5 hours ago, and they've been comfortable and their labs are normal, their urine's normal, and now they feel fine and all their pain is gone and they're hungry. So anorexia is the other thing. Most patients with appendicitis or any kind of peritoneal inflammatory thing don't want to eat. Okay, if your guts are inflamed, you usually don't want to eat. It's not always the case, but it typically is the case. Okay. I'll tell you, I had an 8-year-old boy who was like this chubby little kid, and he had full-on appendicitis, and I was really doubting myself because he had, an hour before I saw him, had a big bowl of like chili. I'm like, how did you eat this? And he was still hungry. He wanted more food. I'm like, there's no way you have appendicitis if you're eating this much. But he had appendicitis. He was, perseverance. He ate through it. So it doesn't apply to everyone, but again, it's one more piece of the puzzle. Okay? But almost everyone doesn't want to eat if they've got truly inflammation of their gut. Now, with that in mind, then you look at the patients that have you're very convinced they have appendicitis. What are you going to do for them?
Take them to the OR.
Yeah.
Okay. And what would you do for them in the OR? Good. And then what if the appendix looks normal when you get in there?
Some people have to
Remove it anyway. Why?
Because if they develop appendicitis later, it's like you were already in there.
So you were already there. It doesn't add much morbidity to take out the appendix once you're already there to the operation. There may be confusion later on when people see the incisions and think it's already been taken out and they ignore the possibility of appendicitis. The patient may be confused and think you took out their appendix because you went to surgery to take out his appendix, and then tell people his appendix is gone. And finally, what if they get appendicitis tomorrow?
Yeah.
Now you're sort of, how often are you going to go back in their belly and check for this pain that is probably not going to go away after your surgery because you didn't do anything to relieve it, right? So it's a good thing to take out the appendix. Now, the other part of that is sometimes even an appendix that looks pretty normal, you take it out, their pain goes away. And so that's not enough of a reason to take it, but with everything combined, just take care of it. Okay. Now, take out the normal appendix. What are you going to do next? What else do you have to do in the operating room? Are you done? You took out a normal appendix.
Just look around and see if there's anything else.
Yeah, you didn't explain their pain, right? So what are the other things you want to look for? Now you've got your work cut out for you. You really have to look around and find a reason for their pain. So what are the other things? It's all the things we mentioned.
Gynecological issues.
You want to look at their ovaries. You want to look for an abscess. You want to look at their sigmoid colon. You want to look at their gallbladder.
You do that while they're open? Yeah.
While you're in there. So if you have if you're doing it laparoscopic, you just take the
Okay.
camera and turn this way and that way and look at everything. What else? What are the other two things I mentioned there?
Chemicals.
So you look for a Meckles. How do you look for a Meckles?
2 feet from the...
Yeah, you follow the terminal ileum back 2-3 feet to make sure you don't have a Meckles there, right? And then what else? Mesenteric Lymphadenitis. So you want to look at the mesenteric, see if they have swollen lymph nodes. Not because you're going to necessarily change what you do, but if you find it, you know it. And if you find the Meckles, then you treat the Meckles, right? You take out the Meckles, and you've taken care of their issue. Okay. An inflamed Meckles will be symptomatic. A Meckles by presence isn't necessarily going to cause pain, right? Yeah.
When you see the mesenteric lymphadenitis, then do you question them like their history, like if they were sick before?
No,
Like,
I
do you
question
find-
them at the beginning when I see them in the ER. I ask them if they've been sick recently, if they have a sore throat, runny nose, cough, cold, other things that would make me think that it's something else going on.
Okay, and if they didn't have that history, but you did, I'm just wondering, like. if
Sometimes
they're-
their history is sort of vague or
Okay,
not
so-
really, or
okay.
you know, I kind of had a sore throat yesterday, and
But, yeah.
then yeah.
Okay, let's say you go in and it's not the appendix, but you've taken out the appendix and you're looking for other causes,
Mhm.
and they have a Meckles diverticulum,
Mhm.
but it doesn't look like that's the cause. Are you going to take that out too? Are you just kind of like
Good
cleaning
question.
up everywhere?
Good question. That's a question that comes up. If you see a Meckles and it's not inflamed, what do you do about it? And you should take it out. Although some people say if it's a broad-based Meckles, you don't have to if it's not inflamed. And then the question is, how should you take it out? Do you just cut the side, or do you wedge it out, or what do you do? And I think that's more of a surgical level question, but it really depends on how it looks.
Okay.
But yeah, if you're there for appendicitis and they have a Meckles, you should take it out,
Okay.
because you're always going to have that question too.
Right.
So
Okay.
this is what it
That's
looks
why
like?
you look for it.
Is that
Yep,
what it looks like?
that's one.
Brown
That's
That's
one way
the
you can
broad
do it.
base?
That's sort of medium.
For your
Oh.
next best step, say it's positive physical exam finding, would you still consider an ultrasound or go straight into surgery?
Well, that's what we're going to talk about. So then the other question is, what's the role of imaging, and what do you do with the people in that middle group? Okay. So appendicitis is supposed to be a clinical diagnosis. Okay. So you should not have to do CT scan and ultrasound and stuff to find the appendix. Okay, so if you have a classic story that's convincing, I would not say I'm going to do imaging. I would go to the operating room.
That'd be
And that's what I do in my practice. If I see a patient in the emergency room and they have a classical appendicitis, I take them to the operating room. Now, that rarely happens to me anymore because they usually don't call me until they've got a CT already. But if I do see them, I take them to the operating room. The question of imaging, so then the other question is, how often should you be wrong, right? How often are you going to, because you can't be 100% right on appendicitis. There's so many other things that can cause it. but you're going to operate, and every once in a while you're going to see a normal appendix. How often should that happen? It should happen about 10 to 15% of the time. And the reason for that is because people have sort of looked at this epidemiologically. If you're not wrong 10 to 15% of the time, you're probably missing a bunch of people with appendicitis that you're saying, I'm not really convinced, I'm not going to operate on them. Okay? You're misdiagnosing those people. If you're wrong more than 15% of the time, you're just operating on everyone with abdominal pain. That's not good either. But you can't, you have that middle ground. Now, with the use of CT and ultrasound, that's getting to be less and less, because the people that you're not really sure of, you have other modalities to check. So that brings us to the third category, the middle patient, where you're not convinced that they don't have it, you're not convinced that they do have it, you're sort of trying to figure it out in the middle. So what can you do? Well, there's several things. There is a scoring system called the Alvarado scoring system, which you can use, and it gives points for all the history things and physical exam things we talked about in their labs, and you can give them, and you can get a score, and it'll basically tell you if they're in that middle ground on the scoring system, you should get imaging. Okay, and it's basically a scoring system to determine if you should do CT or not. And if the score is really, really high, then it's the ones that you're pretty convinced need to go to surgery, and you just go to surgery. And if the score is really, really low, then you don't need to do anything. It's not appendicitis, but you can either pull out the scoring system and score everyone that comes in with right lower quadrant pain, or you can use it on the ones that you're not sure. Because instinctively, the score is going to be high if they've got all the pieces of the puzzle, and it's going to be very low if they don't have any of the pieces of the puzzle. And those you already know, you're going to be pretty certain of. It's the middle people that have parts and pieces of the puzzle and not all of them. And so you can use a scoring system to get you more accurate information. Or you can scan those people. So then the question is, do you do ultrasound or CT scan? What's the advantage to ultrasound?
It's fast.
What is it?
Very quick.
And cheap.
And cheap.
Okay, quick, it depends on where you are. So an ultrasound requires an ultrasound tech to be done, and it's not always readily available if you're in a community hospital on a weekend or at night, because the techs don't hang out in the hospital. CT techs are always in the hospital because hospital ERs have to have CT scans available. If somebody comes in with a stroke or with many other things that need emergency CT scans. Typically ultrasound for emergencies are rare. So most places don't have an ultrasound tech in the hospital off hours. But yes, they are usually readily available and easy to do, especially if you know how to do it yourself. But what's another advantage of ultrasound to CT?
Less radiation.
No radiation, right? Yeah, so radiation. What's the advantage of a CT scan?
More definitive?
So it's more specific and more sensitive, because ultrasound is number one operator dependent. So one ultrasound tech and the next ultrasound tech are not necessarily going to have the same outcome when they look at someone, because it just depends on how you put the probe and what angle you put it, and you guys have seen that here. What images you see depends on how you're doing the test. And so it's operator dependent, and ultrasound's not always able to find the thing you're looking for, right? Whereas a CT scan gives you a picture of whatever's there at the time. Okay. So CT is more sensitive and more specific, and usually more readily available, but it does have radiation as a downside. Okay. And so I usually say CT should be used in the middle ground, and ultrasound is a good tool to use in peds, in kids that you really don't want to radiate, but it's really only good if you're in a hospital that has a good ultrasound tech that's used to doing ultrasounds for appendicitis. Otherwise they won't be able to find it ever. Okay. Now your third option for the middle ground is none of the above. You're not going to operate. You're not going to do imaging. You're going to sit on them. Admit them to the hospital, hydrate them, and wait 12 hours. Wait till the morning. If it's appendicitis, it's only going to progress and get worse, right? If it's not appendicitis, it'll probably get better. So the next day they're feeling better, great, you feed them, they're doing great, they go home. If the next day they're still in pain or getting worse, then more likely that they need surgery. If the next day they're exactly the same as where you started, you still don't have an answer, you got to sort of make a judgment call. Yes?
If they feel better in the morning, let's say because it bursts, how long until the pain returns?
It's very brief.
Okay.
Yeah. So it's not like they burst and then now they're feeling better and then an hour later they're going home because they feel so good.
Okay.
The other question is, how quickly do you need to operate on them? Because we always say, oh, they come in, if you better get to them quick or it's going to burst. No, people have looked at that, and it turns out that people who have ruptured appendicitis typically come to the hospital already ruptured, and people who come to the hospital not ruptured tend to not end up rupturing, usually. So the time frame thing is being more and more questioned. We used to say appendicitis has to be taken out immediately. Now they're saying you can wait 12 hours and it's going to be fine. The outcomes don't really change. So it probably has more to do with the pathophysiology of their disease. And, you know, one person's appendicitis is different than another person's appendicitis, and what's going on may make some people more likely to rupture and some people not. And that's a big part of it. Now, to make things more confusing, recently there was a New England Journal of Medicine article that challenged the idea of doing surgery for appendicitis altogether.
Oh yeah, I saw that.
And this is based on some work out of UCLA, and some people have been doing this, actually in Europe people have been doing this for a while, because in socialized medicine it's much cheaper not to operate on people than to operate on people, right? And ultimately the answer to that article is it's not inferior to do antibiotics alone. In other words, if you end up not operating on someone with acute appendicitis, they've got about a 70% chance of getting better with that and not needing surgery,
If you give
which
them
with antibiotics only. But the way they did it is like days, like I think 5 days of IV antibiotics followed by another 10 days of oral antibiotics. So it's not exactly surgery and then 5 hours later you're at home recovering. Okay, it's days in the hospital and days of antibiotics afterwards. So, and 30% of those patients that were admitted for antibiotics ended up needing surgery anyway. So that, you know, becomes its own challenge. So it's not, it's definitely not better. The only question is, can you do it? And you can safely do it. I think right now the standard of care is still surgery. And if you ask most surgeons, people recover better and do well with surgery than they do with just sitting around doing antibiotics. But the good thing about that data is, let's say you've got someone that's got really bad comorbidities and can't have surgery. Say they got a really bad heart. They had a heart attack 2 weeks ago. Or, you know, and you really don't want to put them under anesthesia. Then you've got a 70% chance of getting them through it with just antibiotics and not needing an operation. Final part of that question is, how many of these people end up needing an or getting appendicitis again? Because that's something you have to think about. They still have their appendicitis. Are they more likely to get appendicitis again? So there is a study from there's two big studies that have looked at this, the VA and Kaiser. because they're the ones that can follow people forever to see if they ever get appendicitis again, because they're sort of in their system, and wherever they go, they're in the system. And you can, you know, if I do something here at Tarzana, the guy might go to Cedars and get his appendix out, I'll never know, right? So those two places have looked at it, and basically one of them said, yeah, they're more likely to get appendicitis, and the other one said the likelihood of appendicitis is about the same as the general population, 1 in 8, and you don't have to do anything about it. And when you tease through the data, it comes out that basically their likelihood of getting appendicitis again is probably not much more than the normal population, but it may be slightly more. If they've got appendicoliths, or little stones in their appendix, then they definitely have a much higher rate of getting appendicitis again, something like 70% or something. And those patients should have their appendix removed because they will get appendicitis again. Everybody else, it's sort of a personal preference. So you sort of offer it to them. You say, you can have it if you want to, but you don't have to have it. The likelihood of getting appendicitis is probably not much more than the rest of the world. Okay? So that's appendicitis in a nutshell.
Did you say there was any distinction between whether the appendix had already ruptured as to whether you could just give the IV antibiotics?
So good question. If the appendix has already ruptured, or if the appendix has ruptured and formed an abscess, those are two other groups of people than the people with just acute appendicitis. So people that have ruptured and already formed an abscess, you don't want to operate on. Mainly because you're going to unroof that abscess and spill it everywhere and make them sicker. And it's going to be very difficult to surgically get to the appendix, which is in this big inflammatory mess. And so their complication rates are higher. So what you do for those guys is typically drain their abscess, like radiology or ultrasound or something will see it, put a drain in it, and give them antibiotics and let it resolve that way. And then you have the question of interval appendectomy once all that goes away, about 6 weeks later. For people who have a perforated appendix without an abscess, that's still in the debated area where some people will say, well, just give them antibiotics and treat it like diverticulitis. And some people will say, we'll just get it out and give them antibiotics after. And so I know a lot of pediatric surgeons will say, don't operate on them. And most adult surgeons will say, just operate on them quickly.
What?
Oh, sorry.
Go ahead.
So for people where it's very clear they have a very classical presentation of appendicitis, are you still scanning them before surgery to see whether they have an abscess? Otherwise, how do you know?
Well, who typically has an abscess? Usually abscesses form after about 5 to 7 days. So if someone's coming in with 12, 24 hours of pain, they're not going to have an abscess usually. If someone's coming in with a week of pain, 5 days of pain, their white count is too high, then, you know, there are things that sort of lead you down the path of, this isn't just early acute appendicitis. I'm going to look into it, scan them to see if they have an abscess. Make sense? And then obviously if there's confusion as to the diagnosis, if you're not really convinced it's appendicitis, but you know, could be, but then there's many other things still in your differential and their history or exam isn't classic, then imaging will help you in those cases. Okay. All right. Let's stop there.